Hello everyone, I'm Tiffany, Research Coordinator on the Emergency Department of Baylor Scott and White Oceans Medical Center. Our project is Intraosseous versus Intravenous Vascular Access during Cardiopulmonary Resuscitation (CPR) for out-of-hospital cardiac arrest (OCA), a meta-analysis study. Our study had no conflict of interest. There are more than 300,000 OCA cases happen annually in the United States, with only about 10% survival at hospital discharge. The resuscitation guidelines suggested epinephrine should be administered in a timely fashion, and several studies have investigated the role of time of epinephrine administration in the survival from OCA. And they found that survival was greatest when given epinephrine early, but decreased rapidly with increasing delay in epinephrine administration. There were 4% decrease in odds of survival for adult OCA with each minute from arrival of EMS to epinephrine administration. So, to administer epinephrine faster, several studies discuss the use of IOSS. And updated guidelines by American Heart Association and European guidelines suggested IOSS can be considered an option other than IVSS. After training, IOSS could be established more rapidly than IVSS by EMS in the field with high success rate. So we have a question. Is IOSS clinically beneficial during CPR for OCA? So we conducted this meta-analysis to determine if the route of medication of administration was associated with neurological or survival outcomes of OCA. So through the database searching, we initially enrolled 1,616 studies, and then we ran through the initial screening, full-text screening, qualitative analysis, and quantitative analysis. Eventually, we enrolled 9 studies to our meta-analysis. All these studies were retrospective studies, and the study period ranged from 2007 to 2017, mostly in North America. The patient number ranged from around 800 to 35,722 patients. About half amount of the enrolled studies had the adjustment of time to intervention. For primary outcomes, 6 studies reported neurological outcomes at hospital discharge. The poor results demonstrated no significant association between vascular access type and neurological outcome. In subgroup analysis, the meta-analysis suggested that time to intervention can be a significant outcome moderator. When the studies not adjusting time to intervention were poor, the heterogeneity decreased, and IOSS was inversely associated with favorable neurological outcome. So it can indicate that time to intervention was positively associated with the poor odds ratio of favorable neurological outcome at hospital discharge. For secondary outcomes, IOSS was inversely associated with short-term survival, while it was not significantly associated with survival at hospital discharge. When studies were stratified on time to intervention, the heterogeneity of the poor odds ratio decreased for both subgroup analyses. Despite that, the association between vascular access and survival at hospital discharge remained no significance. So, when time to intervention is adjusted, the poor odds ratio may be directed toward favoring IOSS. Not accounting for time to intervention can lead to resuscitation time bias. For example, longer time to intervention can lead to longer CPR time. It may itself be inversely associated with outcomes and independent from the type of vascular access. So, time to administering medications is more relevant than time to establishing the vascular access. And only 2 studies consider time to medication administration. Therefore, we should conduct larger clinical trial in future for these topics investigation. Our study limitations included between study heterogeneity, and the study design was retrospective observation, and only one representative effect estimate was abstracted for each study. In conclusion, there was no significant association between types of vascular access and neurological outcomes at hospital discharge among OCA patients. And time to intervention is an important outcome moderator for IV versus IO vascular access in OCA study. Thank you so much.
Hi, everyone. My name is Kevin Gardner, and I'm a critical care medicine fellow at Stanford University. And today, on behalf of our group, I have the pleasure of presenting our abstract, The Relationship Between Prolonged ED Boarding and Mortality of the Critically Ill. So to begin, I unfortunately don't have any financial conflicts of interest to disclose. And for background, today we're going to be discussing ED boarding. So the definition of ED boarding, as I'm sure many of us are aware, is the process of holding patients in the emergency department after the decision is made to admit the patient due to a lack of inpatient beds. And for many emergency providers, this is the thorn in our side because it creates a number of challenges. First, it forces us to go from providing acute initial evaluation and management to providing more longitudinal care, which we're not as familiar with. It also increases crowding and decreases patient satisfaction, along with a whole host of other challenges. And what's more, studies have looked at the negative impact that boarding has on patient-centered outcomes, namely mortality. And what these studies did is they looked at all critically ill patients who ultimately arrived to the intensive care unit, and then they looked back. And when they looked back, they categorized these groups as to whether they had a prolonged boarding in the emergency department before arriving to the ICU, or whether they had non-prolonged or a shorter amount of time boarding in the emergency department. And then they compared the mortality between these two groups. And what they found is that those patients who spent less time boarding in the emergency department had a lower mortality as compared to the group who had prolonged boarding or spent more time in the emergency department. In fact, one study showed that those patients with prolonged boarding had a 2.3% increase in their mortality. And while these studies are very important, our group noticed that they potentially suffer from a selection bias. And the selection bias occurs when we only look at patients who ultimately arrived to the ICU from the emergency department. And when we do that, we potentially exclude patients who are boarding for so long in the emergency department that they actually improved and got better to the point where they were downgraded and then never arrived in the intensive care unit. And by excluding those downgraded patients, that potentially impacts our mortality calculations. So our group's hypothesis was that excluding boarding patients who were ultimately downgraded and never reached the intensive care unit creates a selection bias, which increases mortality. So to do this, our study was a sub-analysis of data from a prior retrospective cohort study. It occurred at our center, which is a tertiary care suburban academic medical center. And we defined prolonged boarding as any boarding in the emergency department greater than 12 hours. And what we saw when we looked at this is we first took patients and we identified all patients who had ICU admission orders at the 12-hour mark. And then we categorized these into prolonged boarding, those patients who spent greater than 12 hours in the emergency department, and those patients who spent less than 12 hours, the non-prolonged boarding group. Within the prolonged boarding group, we further looked and categorized them as to whether they ultimately arrived in the intensive care unit or whether they had improved to the point where they were downgraded and never arrived to the ICU. We then calculated our mortality first by excluding these downgraded patients, kind of mimicking the prior studies that had been done. And then we also calculated our mortality when we included these downgraded patients and we assessed to see if there was a difference in mortality. So what we saw when we did this is first, we saw that we had 244 patients in our prolonged boarding group and 1,413 patients in our non-prolonged group. They were similar in terms of their sex and age, although the non-prolonged group did have a statistically significant increased severity of illness score, which makes sense. Those patients who are sicker are more likely to get an ICU bed quicker than those who aren't. When we looked at mortality, what we saw is when we looked at the non-prolonged boarding group, their mortality was 17.8%. When we looked at the prolonged boarding group, or those who spent longer than 12 hours in the ED, when we first excluded patients who were downgraded and never arrived to the ICU, kind of mimicking those prior studies, we calculated a mortality of 20%, which was increased or above that of the non-prolonged group. When, however, we included those downgraded patients, our mortality dropped to 13.5% and was actually lower than the mortality in the non-prolonged group. Although we should mention that neither of these reached statistical significance. So overall, what this demonstrates is that excluding those downgraded patients increases mortality and does create a selection bias. Said another way, those patients who boarded for a significant period of time in the emergency department, but never improved to the point where they were downgraded, are more likely to be sicker when they ultimately do arrive to the intensive care unit. And none of this is to say that boarding is good or anything like that. It's just to demonstrate that this selection bias does exist, and we need to be rigorous when we're calculating our mortality in these groups. So here are my references, and on behalf of our group, I want to say thank you for coming to our talk, and we really appreciate you being here.
Hello, everyone. I'm Michael Stahl. I'm a fourth-year emergency medicine resident at the University of California, San Diego, and today I'm here to talk to you about female sex and obesity and how they are associated with high tidal volume ventilation in the emergency department. Dr. Wardy received some funds for an unrelated topic in the past. I still have not figured out how to get anybody to pay me for the research that I do. Let's jump right into it. So endotracheal intubation is one of the quintessential skills of an emergency medicine physician. I think we all like to intubate patients. It's exciting to put plastic into a crashing patient's trachea and hopefully drastically alter their course. Mechanical ventilation after we intubate someone just isn't quite as sexy. And so there hasn't been much of an emphasis on this. However, this has been changing with more discussion about appropriate management of the ventilator in the emergency department. I think a couple of things have sparked this, including prolonged boarding times, even before COVID hit, and then the COVID-19 pandemic, which has forced many of us to become amateur critical care physicians, managing really sick patients with ARDS, sometimes for multiple days in the emergency department. Now, low tidal volume ventilation is a well-described intervention, starting with the ARDSNet protocol, that's been shown to decrease mortality in ARDS, decrease the progression to ARDS, and even decrease mortality when started in the emergency department. This is a pretty simple intervention. It's just setting an appropriate tidal volume of 6 to 8 cc's per kilo of ideal body weight. However, emergency medicine and critical care literature has shown that not all patients receive low tidal volumes equally. So we set out to qualify the proportion of patients in the emergency department who received low tidal volume ventilation and to identify any non-modifiable patient characteristics that were associated with receiving high tidal volume ventilation. We did that with a retrospective cohort study at our 2 academic emergency departments. We identified everyone who was intubated in the ED or attempted to during our study period by an automatic query, and we used the same automatic query to pull most of our data. We excluded anyone less than 18 and, due to institutional idiosyncrasies, excluded anyone intubated for trauma. We define low tidal volume ventilation as anyone as less than 8 cc's per kilogram of ideal body weight. We used SPSS version 26 to analyze our data, and we used pretty standard statistical techniques. So we found 1,073 intubations within our study period. Unfortunately, we had to exclude 427 of these due to incomplete demographics, and the majority of those were patients that didn't have a height recorded. This left us with about 646 cases. Our mean age was about 56, 31% were female, about 55% were white, and a quarter were Hispanic. About 25% of patients had a BMI of over 30, and about 50% of patients had a normal BMI. So overall, we found that 120 patients, or about 18.5%, had a tidal volume initially set at over 8 cc's per kilo. 43% of females had an inappropriately high tidal volume compared to only 7% of males. And that difference was statistically significant. Similarly, patients with a BMI over 30, 25% of those had a tidal volume of over 8 cc's per kilo, while only 15% of patients with a lower BMI had inappropriately high tidal volumes. Again, that was statistically significant. In our multivariate regression analysis, we found that both BMI over 30 and female sex are significantly associated with a tidal volume of over 8 cc's per kilo ideal body weight. You can see the odds ratios there. So what does this tell us? Well, female sex and obesity, defined as BMI of over 30, are associated with receiving inappropriately high tidal volumes in the emergency department. I think we can take a few things from this. Estimating patients' ideal body weights is hard. This is because it's only dependent on height and sex, which can be a tough concept to wrap your head around, especially for obese patients, illustrated best by this picture on the left, where you have a giant body with normal-sized lungs. Just remember that lung size is only dependent on height and sex. Measuring your patients is a pretty easy intervention. It's something that I'm going to strive to do for all the patients that I intubate to get an accurate height so I can give them the best tidal volumes possible. And understanding these biases can help us deliver more equitable care to all of our patients, irrespective of their sex or BMI. Of course, this study had limitations. It was a retrospective single institution study. There's no guarantee that the height and weight recorded were accurate or they were put into the chart. And we only recorded the first initial tidal volumes in our study. We didn't look at how rapidly these were changed, maybe in a more appropriate, maybe in a less appropriate fashion. And with that, I'm going to conclude any question, and I'll be taking any questions.
Hello, my name is Onyinyechi Eke, and I am ultrasound faculty in the Department of Emergency Medicine at Massachusetts General Hospital, and I am pleased to present this abstract on behalf of my co-authors. The title of this abstract is Timing of Pericardiocentesis and Clinical Outcomes in Tamponade. Is earlier pericardiocentesis better? I have no conflicts of interest to declare. Pericardial tamponade is a serious medical condition that requires prompt recognition and intervention. With the aging population, there's an increased incidence of malignancy, renal disease, heart conditions, and anticoagulant use, all of which are associated with the development of significant pericardial effusions and pericardial tamponade. In this study, we wanted to determine if the timing of pericardiocentesis affects clinical outcomes in emergency department patients with pericardial tamponade. This was a retrospective cohort study where EPIC, the electronic medical record, was queried between two tertiary care centers. The inclusion criteria were adult patients diagnosed with pericardial effusions or pericardial tamponade who also had a pericardiocentesis within 24 hours of ED arrival. Exclusion criteria were trauma patients and patients with CPR in progress. The exposure variable was time to pericardiocentesis. Early pericardiocentesis was defined as pericardiocentesis that was had within 12 hours of ED triage, and late pericardiocentesis was intervention that was had from 12 hours to 24 hours. The outcomes of interest were procedural complications, ICU admission, length of hospital stay, 30-day survival, and 1-year survival. For statistical analysis, univariate log rank test and Cox proportion hazard models was performed for survival analysis, and propensity score matching was used to reduce selection bias. A total number of 205 patients were included in the analysis, with the early intervention group having 128 and the late intervention group having 77. The mean age was 60 with a standard deviation of 15. 53.2% were female. The most frequent comorbidities were malignancy, hypertension, and coagulant use. And the most common presenting complaint was dyspnea, followed by chest pain. This table shows the proportion of echo findings in the early and in the late intervention group. We see here the right atrial collapse was more frequent in the early intervention group, and that was statistically significant. Exaggerated mitral valve inflow velocity was also more frequent in the early intervention group and was close to statistical significance. We also see here the time to diagnostics and intervention. Of note, this is reported in median time, and we see that the median time to intervention in the early group was 5 hours, and the median time to intervention in the late group was 18.5 hours. There was no significant differences in vital signs, triage complaints, or medical history between the early and the late intervention groups, and there was no significant difference in peri-procedural complications, ICU admission rates, or length of hospital stay between the two groups. This is a Kaplan-Meier curve for the early and the late pericardiocentesis group. The late group is blue and the early group is red. This is for 30-day survival. This Cox regression model shows that early pericardiocentesis is associated with a hazard ratio of 2.9, but this was not statistically significant as the confidence interval here included 1. However, in the 1-year survival analysis, the early pericardiocentesis is associated with a hazard ratio of 3.124, and this is statistically significant. In conclusion, patients with early pericardiocentesis, these are patients who had pericardiocentesis less than 12 hours from ED triage, have decreased 1-year survival compared to patients with late pericardiocentesis, patients who had pericardiocentesis after 12 hours. The limitations of this study include the fact that we queried the electronic medical record for data, and this makes us susceptible to missing or incomplete data. Of note, there might also be a subset of acutely ill patients with pericardial tamponade in whom earlier pericardiocentesis could lead to increased survival. However, that was not reflected in this study. Thank you for your attention. This is a QR code for my references.
Hello, my name is Patrick Tyler. I'm an emergency medicine research fellow at Beth Israel Deaconess Medical Center in Boston, here to tell you about our group's work on thromboelastography to assess coagulopathy and glycocalyx degradation in sepsis. So sepsis is a common clinical syndrome affecting our patients, and we know that the inflammation of sepsis causes abnormal coagulation through activation of the coagulation cascade. We know that sepsis damages the endothelial glycocalyx, which is the innermost layer of our blood vessels, and that inflammation shears proteins off of the blood vessel surface, proteins like heparan sulfate, which can then be released into the circulation and are biomarkers for glycocalyx injury and might cause coagulation disturbance. We might be able to measure some of those disturbances using viscoelastic monitoring, of which the most familiar technique to us is thromboelastography. This is frequently used in trauma, cardiac surgery, and liver surgery, and the technique is as follows. A small sample of blood is placed into a cup, and then a pin is immersed into the blood, and the cup and the pin are rotated relative to one another as the blood clots, and this can be transduced into a force diagram. Different elements of this force diagram can be measured and quantified, and these relate to different elements of the coagulation cascade. So we can obtain those measurements for a sample of blood directly from the patient, but if we think there may be endogenous or exogenous heparinoids, we can perform another test with heparinase added to the blood, and the difference between those two samples is the delta of the particular parameter. And we think that through these parameters, we might be able to detect glycocalyx injury at the bedside. So we hypothesized first that coagulation abnormalities detected using TAG would be associated with organ dysfunction in patients with sepsis. And second, the TEG abnormalities would be associated with glycocalyx dysfunction. We measure the first hypothesis with SOFA score, and the second using serum levels of heparan sulfate. So we performed a prospective observational study of emergency department patients greater than 18 years who came in with sepsis, and we obtained baseline blood samples which were sent for viscoelastic testing. Our primary exposures were these TEG parameters that you see there, and the primary outcomes were the sequential organ failure assessment score on enrollment and serum levels of heparan sulfate on enrollment. To evaluate these measurements, we looked at Spearman correlation coefficients, assessing the relationship between TEG and the enrollment SOFA score and the total heparan sulfate concentration. And then we also performed linear regression in multiple formats, which I'll explain further in a minute. In terms of our results, so like many researchers here, our project was delayed due to the pandemic, but we have enrolled 76 subjects to date and our enrollment continues. In terms of examining the distribution of our patients, one thing you can see here, so we have the number and the proportion of patients, but about 70% of our patients have either severe sepsis or septic shock. This table shows our correlations, and so we have the enrollment SOFA score and heparan sulfate level, and the white rows show the Spearman correlation coefficient, and the gray rows show the relevant p-value. What you can see here is that when we look at the correlations between the enrollment SOFA score and the TEG parameters, there's only one significant correlation between the change in the R time, or the delta R, and the SOFA score, and it's barely significant. When we look at the heparan sulfate level, we can see that there are multiple strong significant correlations. We get similar results if we look at those parameters by using univariate regression. So if the outcome is the enrollment SOFA score and the predictors are the TEG parameters, each of these lines here is a separate regression procedure. And you can see that when we look at the enrollment SOFA score, no significant relationships except the delta R. But if we look at the relationship between the TEG parameters and the total heparan sulfate level at enrollment, there are multiple strong significant relationships. Finally, we could ask whether that relationship might be modified by illness severity. And so we performed multivariable regression where the outcome was total heparan sulfate. And in the model, our covariates included the TEG variable and the sepsis severity. And we can see here, so each of these lines represents a separate regression procedure. And we can see that even after adjustment for illness severity, multiple parameters, all but the LY30, showed a significant relationship between the TEG parameter and the total heparan sulfate level. There are several limitations. So first is that our study is still ongoing and we have relatively small group sizes. Our biomarker testing for abnormal coagulation and endothelial injury to complete our study has not yet concluded. And finally, this is a single center study. So in conclusion, for our first hypothesis, we have not found clear evidence that TEG parameters are associated with organ dysfunction. However, we have found some preliminary evidence to suggest that TEG parameters are associated with biomarkers of endothelial glycocalyx injury, even after accounting for sepsis severity. In terms of ongoing work, we plan to complete enrollment and to complete our biomarker testing for coagulopathy and endothelial dysfunction to generate additional insights into the relationships that we see here. So I'd like to acknowledge the Shapiro Research Group and all of our research team, our colleagues at the IDMC Emergency Medicine, our study collaborators, and also the patients who make these discoveries possible. So thank you very much for your time and attention, and I welcome any questions or comments. My email address is at the bottom of the slide.
I'm Dr. Lina Mata. I'm a research associate and program manager in the Department of Emergency Medicine at the University of Colorado. This presentation is about a modified Delphi process used to define early resuscitation outcomes for a large South African trauma study. I would like to acknowledge multiple collaborators from the U.S. Department of Defense, the University of Colorado, the Western Cape Government, and Stellenbosch University in South Africa, as well as Denver Health and Hospital Authority. We have no conflicts of interest. This research is funded under a Department of Defense grant. As background, we have that trauma continues to be a leading cause of global morbidity and mortality. It disproportionately affects low and middle income countries, which are faced with twice the injury mortality. South Africa is no different. South Africa has 8 times the global mean mortality rate resulting from interpersonal violence. Pre-hospital care offers a reliable and cost-effective opportunity to deliver early resuscitative trauma care. Yet further research is needed to describe pre-hospital care in trauma patients. In 2019 and 2020, the U.S. Department of Defense funded a pair of research studies titled The Epidemiology and Outcomes of Prolonged Trauma Care, EPIC, in the Western Cape province of South Africa. The goal of these studies are to assess relevant mortality and morbidity outcomes due to the timeliness of pre- and in-hospital resuscitation of injured patients. As a first step to conducting this large multi-center study, we conducted an expert consensus process to define critical clinical outcomes needed to evaluate early resuscitation within the South African trauma care system. We used a modified Delphi process to determine expert group consensus. We invited a multidisciplinary group of panelists. We had set an initial goal of 18 to 22 panelists. We reviewed the variables relevant to answer the EPIC research questions of morbidity and mortality outcomes. We collated and prepared relevant findings for presentation to the expert panel, and we used an online electronic platform as an optimal format for consensus building. Consensus was defined a priori as greater than or equal to 80% or similar votes on one item. Here we have an example of what our consensus building interface looked like in REDCap. We presented an initial rationale for the variable or item we wanted to reach consensus on. Then we presented the panel with questions, and then we collected their responses and comments. Results. We had a total of 20 U.S. military and international civilians participate in 3 rounds of surveys with 100% response rate. Consensus was obtained for 8 items. I will be focusing on the 3 main items for this presentation. For our first item, we presented the panel with all-cause mortality time endpoints. Most trauma outcome studies assess mortality at 28 to 30 days. Although no consensus was reached by our panelists for this study, earlier time points, which are between 24 hours to 7 days, were strongly preferred compared to later time points by most panelists. Reasons behind earlier time points included that 24 hours and 72 hours best reflect pre-hospital and very early hospital interventions, including life-saving interventions, and 7 days reflect not only the non-survivable group plus the early intervention group, but it also reflects those with significant morbidity, such as organ failure due to early resuscitative interventions. As our second item, we presented the panel information regarding 3 different scoring systems to assess post-trauma multiple organ failure. The sequential organ failure score, the SOFA score, was selected by the panelist, and we will be using that as our primary measure of organ failure. This SOFA score is most commonly used in South Africa, and it also showed to be the most balanced relation of sensitivity and specificity. We also asked the panel to rank time points for assessing mortality in traumatic brain injury patients. The panel agreed that assessing mortality at 7 days in TBI patients best reflect pre-hospital emergency department care. We presented additional items to the panel as well, and we decided that we will be capturing comorbidities based on the U.S. National Trauma Data Standard List. We'll be using a hybrid injury severity score system. We will use a Nobel 3-tier trauma death categorization system as well. In conclusion, we successfully used a modified Delphi process for defining outcomes for a large trauma outcome study in South Africa. We will incorporate these findings and initiate pilot data collection for our EPIC study. Thank you.
Hello, my name is Lakshman, and I work as a biostatistician at the Center for Resuscitation Science. I'm going to talk to you today about a paper, Thiamine Supplementation in Patients with Alcohol Use Disorder and Critical Illness. This study was funded by our NIH RO3 grant. A little bit of background. Patients with alcohol use disorder are at risk of thiamine deficiency. And this is a problem because if it's left untreated, it can cause death in about a fifth of the patients and can cause irreversible neurological damage in 85% of patients. The main way to treat this is by supplementation with thiamine. We hypothesize that critically ill patients presenting with alcohol use disorder receive less thiamine than those presenting with alcohol withdrawal alone. So the goals of this paper are really to characterize how patients with certain critical illnesses like septic shock, TBI, and DKA are less likely to receive thiamine supplementation than patients with alcohol withdrawal alone. We also want to examine to see if there's a trend in proportion of patients in each group who receive thiamine over time. So to do this, we used the Cerner Health Facts database, and we looked at index ICU encounters for adults between the years 2010 and 17. We used ICD-9 and 10 codes to look at 4 different critical illnesses of interest, that is alcohol withdrawal, septic shock, TBI, and DKA. Our outcome variable was the administration of thiamine during the ICU encounter, and we use generalized estimating equations to do this, especially because these ICU encounters are clustered within hospitals. We needed to account for the correlation within a hospital, so we used an exchangeable covariant structure. We did this analysis unadjusted and adjusted for patient, hospital, and geography characteristics. We also did a non-parametric test for trend in each group to test if the proportion of patients receiving thiamine changed at all over the years. It's a quick recap of the flow of patients through our cohort. After all of our exclusions, we had about 15,000 index ICU encounters, which we classified into 4 primary critical illness groups. There is a 5th group all the way to the right called combinations, but I'm going to remove it from here because it accounts for only about 10% of the data. And since we weren't really interested in this group, we didn't analyze it as such. So for the rest of this presentation, the results are going to be for these 4 critical illnesses. So the cohort at this time was about 13,500 patients. And to summarize the characteristics you see here, about 3/4 of the population comprises of alcohol withdrawal patients, tend to be between 40 to 50 years of age on average, tend to be mostly male, and mortality tends to be similar amongst groups, except for the septic shock group, which is higher. Here are some of the results for the proportion of thiamine supplementation. Each group on the x-axis is a distinct illness group, except for the one all the way to the right, which is all patients. On the y-axis, you have the number of patients in each group, and the proportion of the blue bar represents the proportion of patients in each group who receive thiamine. Results from our GEE in both unadjusted and adjusted analysis, the DKA, TBI, and septic shock groups had lower odds of receiving thiamine. I want to direct your attention to the figure here for a second. The x-axis shows the odds ratios for receiving thiamine. The y-axis shows the different illness groups. The upper part shows the unadjusted analysis results. The lower part shows the adjusted analysis results. The vertical dotted line shows the odds ratio for the reference group, which is 1. And the thing I want to draw your attention to is the fact that all of these dots and these intervals are all the way to the left of the dotted line, which means that all of these groups had a statistically significant lower odds of receiving thiamine compared to the reference alcohol withdrawal group. For the exact numbers, you can see the second and third bullet points. Tends to be only about, it's about 70% lower odds for septic shock and for TBI and DKA. And these numbers tend to be seen whether you look at unadjusted or adjusted. For the results for the trends over time, on the x-axis, you can see the years from 2010 to 17. And on the y-axis, you can see the proportion of patients who receive thiamine broken out by different illness groups. So you can see visually all of these seem to decline over time, but the decrease was only statistically significant in the alcohol withdrawal group, the DKA group, and in the full cohort. So in conclusion, only about half the AUD patients in the ICU get thiamine contrary to guidelines. Critically ill patients with septic shock, DKA, and TBI have a lower utilization of thiamine in the treatment than those with alcohol withdrawal alone. And there was a significant decreasing trend of thiamine use in the full cohort and in patients with alcohol withdrawal and patients with diabetic ketoacidosis. Some of the limitations are that we didn't have too many observations in the years before 2010. We also couldn't manually verify some of these variables because of the de-identified data set. and we also did not determine dose or duration for thiamine administration. In conclusion, I would like to thank all of my collaborators at the Center for Resuscitation Science, with special thanks to my supervisor, Anne, and other colleagues, Mike, Ari, and Rahul. Thank you all for this opportunity.
Hello, my name is Michael Soulis, and I'm a fourth-year medical student at Stony Brook University. Today, I'm going to be presenting results from a project that I've been working on with Dr. Henry Thode and Dr. Adam Singer, looking at asthma COPD overlap in the ED. There are no conflicts of interest to disclose for this project. So what is asthma COPD overlap? Well, it hasn't been precisely defined, but generally the term refers to patients who have features of both diseases. Prior epidemiological and biomarker studies indicate that overlap patients are a distinct population and have increased risk of poor outcomes relative to either disease alone. It is unclear what the ED experience of this patient population is, and therefore the purpose of the present study was to delineate the ED experience of this patient population and compare it to either disease alone. Our primary outcome measure was mortality, and secondary outcomes were prevalence, demographics, status on arrival, medications including albuterol, and systemic corticosteroids, as well as antibiotics, relevant procedures, admission to the hospital or ICU, length of stay both in the ED and in the hospital if admitted. We performed a secondary analysis of ED visits from the National Hospital Ambulatory Medical Care Survey from 2005 to 2018. These years were chosen because prior to 2005, the surveys did not include status on discharge, and 2018 was the most recent year available. All possible ICD codes for asthma and COPD were used to classify ED visits. If an ED visit had an asthma diagnosis without a COPD diagnosis, it was classified as being asthma only. If an ED visit had a COPD diagnosis without an asthma diagnosis, it was classified as being COPD only. If a patient had both a COPD and an asthma diagnosis related to the ED visit was classified as overlap. Approximately 1 million ED visits were classified as overlap, 15 million were classified as asthma only, and 31 million were classified as COPD only. Here are the time trends for each respiratory disease group from 2005 to 2018. The majority of chief complaints for each group were respiratory related, as shown in this figure. Demographically, overlap patients were similar in age to asthma-only patients and younger than COPD-only patients. In terms of sex, race, and ethnicity, overlap patients were more similar to asthma-only patients than COPD-only patients. Overlap patients were also more likely to have greater than or equal to 3 diagnoses related to the visit. These are the presenting vital signs and length of ED visit for each group, with the analysis of variance adjusted for demographic variables and number of diagnoses related to the visit. Overlap patients were tachycardic relative to asthma-only patients and were hypertensive relative to COPD-only patients. Overlap patients were less likely to require immediate care on triage than either disease alone. All 3 groups had similarly low mortality in the ED. There were similar rates of CPR and intubation between groups. However, overlap patients were more likely to require nebulizer therapy and albuterol relative to COPD-only patients. Overlap patients were also more likely to receive systemic corticosteroids relative to COPD-only patients. Overlap patients were more likely to receive antibiotics relative to asthma-only patients. Analysis of variance adjusted for demographic variables and number of diagnoses related to the visit demonstrated a significant difference in mean length of hospital stay between groups, with COPD-only patients having the longest length of stay. However, pairwise comparisons were not significant. COPD-only patients were more likely to be admitted to the hospital than overlap or asthma-only patients. Moreover, overlap patients were less likely to be admitted to the ICU if admitted relative to either disease alone. All 3 groups had similarly low mortality rates, but the overlap group was the only group to have no deaths. Multivariable analysis adjusting for demographic variables and diagnoses related to the visit showed that overlap patients were less likely to require immediate care on triage. Overlap patients were more likely to require nebulizer therapy and systemic corticosteroids relative to either disease alone. Overlap patients were more likely to receive antibiotics relative to asthma-only patients. Although admission to the hospital did not differ between groups, overlap patients were less likely to require ICU admission than either disease alone. These results show that overlap patients differ demographically compared to COPD-only patients and appear to be more similar to asthma-only patients. But in terms of outcomes, This population appears to have different outcomes, both in terms of acuity and severity of presentation relative to either disease alone. This suggests that this patient population is distinct from either disease alone and may benefit from different treatments. Increased medication administration in this population could be due to increased patient complexity or provider uncertainty, and decreased rates of ICU admission could be due to increased rates of medications administered. There are several limitations of this study, including its retrospective nature, uneven population sizes, low mortality rates, and lack of full characterization of each population. In conclusion, overlap patients are less likely to have a severe ED presentation compared to either disease alone. Overlap patients were less likely to require ICU admission relative to either disease alone, and overlap patients were more likely to receive respiratory therapies compared to either disease alone. Here are the references for this, and I'd be happy to answer any questions if there are any. Thank you.
Good afternoon. I'm Dr. Kyle Boyle with Baylor College of Medicine. Today, I'm going to be presenting remote dielectric sensing REDS versus chest X-ray in dyspnea. I have no financial disclosures to make. Here, we used a novel device referred to as REDS, remote dielectrical sensing. It's a device which uses radar to evaluate water content. Originally developed as a tool used in search and rescue to detect human bodies, now it's been utilized to evaluate lung fluid measurements, specifically the right middle lobe. It provides a non-invasive transcutaneous objective measurement within 90 seconds. Physiologic lung fluid is 20 to 30% as a baseline. Here's the device which we utilized. It consists of two parts. The computer part, which is mounted on the mobile platform, along with the patient detector part, which is applied to the patient. The purpose of this was to evaluate the accuracy of REDS to detect lung fluid in ED patients with undifferentiated shortness of breath. We chose the chest X-ray as the gold standard because that's the most common imaging modality to evaluate for volume overload in the emergency department. Patients were included if they had a chief complaint that was coded as shortness of breath. They were greater than or equal to the age of 21, and they provided informed consent. Patients were excluded if they had sustained chest trauma, if they had an illness or condition aggravated by the device, such as a skin disease, fractures, or an unable to wear it, if they had an anatomic abnormality, such as dextrocardia or lung carcinoma, or if they had implanted devices, such as a pacemaker or port. They were excluded if they were too sick to participate. They were excluded if the device did not fit. That is, they were shorter than 5'1" or taller than 6'4", or if they had a BMI less than 22 or greater than 36. They were also excluded if they were pregnant. Data was collected from medical records. The REDS vest was applied and output recorded by study personnel. The output was not available to treating physicians. A chest X-ray is obtained in normal course of care, was read by the attending radiologist on duty, and was then coded as wet or dry by study personnel. 128 patients were enrolled in the study. 60% were male. Ethnically, the breakdown was 46% Hispanic, 35% African American, 13% white, and 6% Asian. Here's the receiving operating characteristic curve, which was used to find the optimal cutoff for the volume overloaded versus non-volume overloaded patients. The optimal cutoff was determined to be 41% in order to correctly identify true positive volume overload patients versus true negative not volume overload patients. The area under the curve was 85%, which indicates a high value, indicating a good level of separability between patients who were volume overloaded and those that were not. Our study had some minor limitations. It is a single center study. We do have a predominantly Hispanic population, and our sample size is somewhat limited. Our conclusion based on our data was that using a cut point of 41%, the REDS device has excellent specificity and negative predictive value for detecting pathologic lung fluid. What's next? Studies using this device are ongoing and is currently being used to monitor heart failure progression in patients at a heart failure center. Goals would be to expand to a multi-center study in order to increase the patient population and broaden our demographics. The ultimate aim is to evaluate if the REDS device can be used in a way to shorten time to diagnosis and treatment. Because it's non-invasive and does not expose the patient to radiation, could it be used on the triage level to determine patients who are volume overloaded or not at the time of chief complaint collection? Could this better help establish initial differential? Could it reduce additional testing? Again, I'm Dr. Kyle Boyle with Baylor College of Medicine. Thank you.
Hello, my name is Dr. Trevor Maddox, PGY3 at Wake Forest University School of Medicine Emergency Medicine program. I will be presenting our lightning abstract on end-tidal carbon dioxide changes during prolonged mask use by emergency department providers. Our PI is Dr. Bozeman, professor at Wake Forest University School of Medicine. Background and objectives. During the COVID-19 pandemic, the CDC recommends healthcare personnel always wear a mask on shift. Previous research has suggested that residual exhaled air is trapped by masks is hypercarbic and that CO2 can accumulate in an N95 in an ICU setting. Our objective was to determine if prolonged mask use results in an environment of carbon dioxide retention and accumulation. Our methods. We were designed as a prospective observational study. We utilized a convenient sample using healthy ED volunteer clinicians. Previously to performing the study, we had decided that 11 patients were required to achieve the desired power. We recorded end-tidal CO2 measurements at baseline and every 2 hours during shift on an 8-hour clinical shift. To the right is a sample of the data collection form that was used, which was filled out at the beginning and every 2 hours throughout the shift by the participants themselves and then submitted. We used a standard sampling nasal cannula for end-tidal CO2 on the left, probably common to all of your emergency medicine departments. To the right is a picture of the card that we had used attached to the end-tidal CO2 measuring device that was positioned in the break room and at the nursing station for ease of use. We performed a repeat measure analysis of variance, comparing each subject's end-tidal CO level to their own baseline and previous measurements. Specifically, we compared to the last previous measurement. In total, 44 subjects participated with a mean age of 31.5 years. Range 23 to 54. Our participants included RNs and NAs, physicians, RTs, medical students. 75% of participants were female and 25% were male. We had all kinds of mask types. 77.3% wore surgical masks. 11.4% wore a combination of masks. 4.5% did not indicate mask type. 4.5% wore N95 masks and 2.3% wore a fabric mask. And this is our analysis of our data. Our mean baseline plateau end-tidal CO2 was 32.5 millimeters of mercury, and mean 8-hour end-tidal CO2 was 34 millimeters of mercury, with a p-value of 0.38 by repeat measures ANOVA. This, as you know, is not statistically significant for change. Mean change from last end-tidal CO2 level ranged from negative 0.2 to positive 1.1. The above data was adjusted by removal of outliers. Specifically, there were several data entries for which initial range was far off from physiological baseline and was favored aberrant. So based off of this, prolonged mask use did not result in statistically significant end-tidal CO2 level changes in an ED providers over the course of an 8-hour shift. Concerns that a hyperbaric mask environment may result in significant CO2 retention are not supported. And these are our references. Thank you very much for your time.
Hi, and welcome to this lightning oral presentation. I'm Sarah Kleinschmidt, a PGY4 resident at Boston Medical Center, and I was joined on this project by Julianne Dugas, Carrie Nelson, and our senior investigator, James Feldman, all from the Department of Emergency Medicine. We have no conflicts of interest to disclose. We do have an institutional grant that supports the clinical data warehouse, and the study was approved by our IRB. Urine pregnancy testing is one of the most common studies that we order as emergency physicians, but there's limited evidence on its real-world performance. In perfect conditions, it has a reported sensitivity of at least 97%, and there are some small studies within the ED that report false negative rates of less than 1%, though only one abstract looked for pregnancies that were diagnosed after the initial visit. This study was actually prompted by a morbidity and mortality case, which led us to wonder, what is the chance of a false negative result? Our secondary aims were to determine this prevalence among patients with symptoms concerning for possible ectopic pregnancy, as well as to discover the outcomes of these cases and the serum HCG level at the time of the false negative. To accomplish this, we undertook a retrospective cohort study, broadly including patients with a chance of pregnancy who had a negative urine pregnancy test during their ED visit. In addition, we predefined a subset of these patients to be high risk for ectopic pregnancy based on a triage chief complaint of abdominal pain, pelvic pain, or vaginal bleeding. Within the whole cohort, we performed chart review for any patients with evidence of a pregnancy within 90 days of their initial ED visit, including positive serum or urine test results, pelvic ultrasounds, or ICD-10 codes. Charts were reviewed for the following outcomes. Did a pregnancy exist? And if so, was it present at the index visit using dating guidelines from the American College of Obstetrics and Gynecology? We also used imaging, lab results, and specialist documentation to classify pregnancies as intrauterine, ectopic, or abnormal, including spontaneous abortion. As expected, we had a small number of patients with indeterminate outcomes due to limited data. We also performed 2 planned sensitivity analyses for cases meeting borderline criteria for their diagnosis or dates. You can see our results here. We had 10,924 patients who met initial inclusion criteria, including a negative pregnancy test in the ED during the study period. Of these, 383 met criteria for chart review, and 306 patients had a pregnancy diagnosis. A total of 171 patients had pregnancies present at the index visit, including 12 ectopic pregnancies. The majority of these false negative results were in our previously defined high-risk subgroup, meaning patients who initially presented with abdominal pain or vaginal bleeding. This includes 10 out of the 12 ectopic pregnancies. We calculated a 3.93 risk ratio comparing the risk of a false negative in this subgroup to patients without those chief complaints. Our confidence intervals are shown, and our sensitivity analyses yielded a maximum range in false omission rates from 1.2 to 1.8% for the total cohort, and from 2.9 to 3.9% for the high-risk subgroup. The majority of our cases were in fact recognized at the index visit, with 124 patients having a concurrent serum HCG level drawn in the distribution shown here. In summary, we found that 1.6% of negative urine pregnancy results were false. This may be sufficient for some applications, depending on the prior suspicion and the risks within a false negative result. For instance, urine pregnancy testing does meet current radiology standards prior to radiation exposure. On the other hand, patients with abdominal pain or vaginal bleeding had an almost 4-fold higher risk of a false negative result, including most of the abnormal pregnancies and almost all of the ectopics. While the majority of our cases were diagnosed at the index visit, we did identify multiple delays in care. Especially given the implications of a false negative result, it seems urine point-of-care testing is not sufficient to rule out life-threatening diagnoses for symptomatic patients. Our concurrent serum values are consistent with prior reports of false negative results at low HCG levels. However, we also found a broad distribution that may reflect an interfering hook effect at high concentrations, as well as other mechanisms. This study is certainly limited by being a single center as well as a specific assay. Results may vary depending on patient characteristics as well as specific process factors, such as how the tests are administered or the results entered into the record system. There is some evidence that different assays have varying sensitivities, especially at low concentrations. It should be noted that our specific assay is only approved for use prior to 8 weeks after the last menstrual period. We were unable to find this information reliably documented by EM providers, and we do believe that our results reflect how this assay is commonly used in a busy emergency department. As mentioned, there are also some inherent uncertainties to pregnancy dating. To mitigate this, we used the most established guidelines, discussed our criteria with an obstetric attending, and also performed a sensitivity analysis for any cases with less than 7 days gap between the dates of conception and the index visit. Overall, we believe our results should caution providers against using urine point-of-care testing to rule out life-threatening complications of pregnancy, in part because false negative results appear to be more common among patients with symptoms of ectopic pregnancy. Further research could build on these results by studying different assays or point-of-care processes. Ultimately, we could trial alternative testing approaches, such as universal serum testing, using serum to confirm negative results, or even developing clinical decision tools that could target serum testing to the highest risk patients. We have some key references listed here, and this project has been accepted for upcoming publication in the Journal of the American College of Emergency Physicians. We owe a huge debt to Linda Rosen from the Clinical Warehouse, Glenn Markinson from our OB department, and our emergency department research staff. Thank you for listening. We're happy to take any questions online or via email as listed here.